Okay, well, in the interest of time and to make sure we give Dr. Dougherty all the hour that she might need, I'm going to go ahead and kick this off. Welcome to Geriatric Medicine Grand Rounds. And it's my pleasure to introduce Dr. Kayla Dougherty, Doctor of Physical Therapy and the residency coordinator for the SSM Health Physical Therapy Women's Health Residency Program, which is very exciting because we're all in medical education and you are as well. So you can give us your perspective both from a clinician as well as an educator, and that's very exciting for us. She's a board certified clinical specialist in women's health physical therapy and is a cancer rehabilitation specialist. And this is so close to home because just today I had a woman who has pelvic pain, a 91-year-old, and I said, aha, I think I have an opportunity for you. So I'm very excited to hear your presentation today about pelvic therapy for older women. So thank you very much.
Yeah, absolutely. I'm happy to be here. So let me start screen sharing. All right. Can everybody see? All right, beautiful. Yeah. I was saying in the beginning too, so I am very much a answer questions as you go person. I don't want anybody's questions kind of lingering out there. So feel free to interrupt me, unmute, say something. Dr. Gamick, if you want to monitor the chat and shout it out if something comes up, I'm happy to answer as I go. I am very used to, so I give the pelvic health gender content for the first SLU's doctorate in physical therapy program, and I've got like 5 or 6 hours to try and jam everything in. So I'm very used to trying to get a lot in a short amount of time, but I'm happy to be interrupted to answer any clinical questions you may have. So I don't have any relevant disclosures. My objectives are really so that you learn a little bit more about what we do and what things look like, a little bit about the kind of complexities of what we think about as a provider when we're having someone that comes in with maybe something that may seem straightforward like stress incontinence, but that there's a lot to kind of unpack with even straightforward diagnoses, and to give you a little bit of a window into what we're looking at, how we're looking at it, and what we do about it. And also recognize a little bit of the breadth of stuff that we can do. Obviously, we're not going to have time to talk about all of the things that we can touch on kind of in pelvic PT as a whole, especially in the aging adult, but just to kind of get a sense of what we're doing, and then to give you some resources of, if you want to refer people, what that can look like. So I'm not going to spend too much time on me. I graduated from SLU's PT program in 2014. I actually started my career in more inpatient neuro rehab, so rehabilitation, hospital, spinal cord injury, brain injury, stroke, more like post-acute care. Did a pelvic health residency in 2016 to 2017 through University of Pittsburgh Medical Center. And I've been back with SSM Health PT since 2017. And we started a women's health pelvic health residency in conjunction with St. Louis University, which started its first cohort in August of last year. And that cohort will be finished in December of this year. We just started our new cohort in August of this year. So they run for 16 months, but we get a new cohort every 12. So we're very excited about that. So you guys probably know what PT is, right? And that you're working with kind of older adults who oftentimes are referred for PT. So we're providers that are really just trying to improve function, independence, quality of life. Yes, we often think of that through exercise, but we're also kind of zooming out and looking at biopsychosocial factors that are both personal and structural that can be contributing to why someone might be having an impairment or a functional limitation in a certain kind of avenue or activity. We definitely work along a continuum of care. So obviously there's PTs that are working like acute hospital, and then there's PTs that are working in long-term care. There's PTs, again, in an outpatient setting, in a neuro rehab setting, home health. So we're kind of all over. And we often think of pelvic PT in an outpatient setting, but we're also trying to have more connections in with like the Day Institute or inpatient rehab or even acute care, recognizing that pelvic health needs are all over the spectrum as far as acuity. And addressing pelvic health needs, even in like an acute setting, may help further participation in that setting as far as PT or mobility or other things that may help people be more successful. There are currently 10 areas of board subspecialty, board certified subspecialty within PT currently, women's health / pelvic health being one of them. But we have geriatrics, oncology, orthopedics, pediatrics, sports, cardiovascular. So there are certainly PTs that have a subspecialty or interest in a certain kind of population or caseload. So what is pelvic health PT? I think that some of those subspecialties make a lot of sense to people intuitively, like, okay, we understand what orthopedics is, we understand what geriatrics is, we kind of understand what neuro is. But I think sometimes pelvic PT is this kind of black box over in the corner of like, I don't know, they do this stuff with the things and the pelvis and the leaking and the stuff. And so I'm hopeful to kind of give you a little bit of a better window into kind of who we are and what we do. So I'm a PT just like any other PT with additional kind of training, certification, understanding of things like anatomy, physiology, function of, yes, the abdomen and the pelvis, so visceral structures, pelvic floor specific structures, disease processes that affect kind of pelvic health through the lifespan. That's from pediatrics all the way through to aging adults, including, you know, pregnancy and postpartum, menopause, osteopenia, osteoporosis, bone density changes, all of that kind of stuff. And so we are assisting people kind of through the lifespan with any and all of these diagnoses that you see here, not just keeping our eye on pelvic floor, but recognizing kind of that holistic zoomed out view of all of the things that could potentially contribute to someone having a deficit or an impairment during any phase of their life that could affect their pelvic health, bladder, bowel, sexual function, or otherwise. So why does pelvic health matter for adults as they age? So this is certainly not an exhaustive list, but there can be significant costs, both actual financial costs as well as like health-related quality of life costs for people that are experiencing pelvic health impairments at any phase of life, but especially as they age. So not only the things like the cost of treatment for incontinence, whether that's pads, diapers, surgeries, medications, downstream complications from things like skin integrity issues or otherwise, level of continence being associated with, you know, level of care. It may be the difference between someone being able to be at home or in assisted living versus needing a higher degree of care long-term. Severity of incontinence is significantly linked with navigation and confidence outside the home, as well as participation in things like activity and exercise. Urge incontinence specifically of 1 time or more per week can significantly increase risk of falling or fractures. Nocturia associated with a 3-fold increase in depression amongst women who reported sleep disturbances secondary to urological function, as well as, again, older adults are still sexually active, and recognizing that quality of life for older adults who are having sexual dysfunction and want to participate in sexual activity is significant. Again, not an exhaustive list, but certainly a lot of both quality of life issues as well as just financial and ability to stay independent issues. So why is pelvic health in aging adults so complex? So I think pelvic health at baseline can be complex because there's so many factors to consider, but especially as people age, we have some modifiable and some non-modifiable factors that we're dealing with. That's, you know, visceral changes, cognitive changes, polypharmacy, increased incidence of comorbidities that affect their mobility and their general health, sleep quality, right? So we know that sleep quality as we age can be challenging, and that people with poor sleep quality also tend to report more total incontinence episodes per day as well. Decreased social network and stigma too. I think that while I don't want to paint with too broad a brush, you know, as far as like generationally, I often see older adults have potentially more anxiety about getting in the door, and more potential difficulty discussing some of these more what they consider kind of really intimate and personal and oftentimes embarrassing things with another person, and that can certainly be a barrier to entry for some. So when we think about frailty in pelvic health, that kind of conception of a person that we think of as frail, with weight loss, decreased physical activity, slower walking speed, kind of that tiredness or exhaustion factor, I think that we can understand conceptually how a person that we see as frail is more likely to potentially have pelvic health issues, right? So if they're weaker, then their muscles are weaker, including potentially pelvic floor muscles, hip muscles, muscles that help them to do effortful tasks. If they're having slow walking speed, poor aerobic capacity, decreased physical activity, right? Their ability to get up out of a chair without leaking, be able to walk to the bathroom in time to be able to get there. We could see how those factors potentially lead us to greater pelvic health concerns. That includes things like constipation, right? When we don't move as much, when we're not eating as well, our bowels don't move as well. And when we're more constipated, we're oftentimes less likely to move because we don't feel great. And that constipation can also be a factor in things like urgency and urgent incontinence. So that kind of train of thought and that domino effect makes sense. But what I also want to make the case for is the inverse, and how pelvic health concerns can set someone up for potential increased risk for kind of frailty and decline down the line, right? So we can have a lot of, and there's studies that show kind of that fear, embarrassment factor related to leaking, and I'm going to narrow it down to leaking for this example, can really limit people's participation in exercise, as well as fear of getting out of the house. So a lot of my patients are fearful to leave their house because they're not sure when they're going to come across a bathroom. They're worried about making it in time. They're worried about having an accident. And so they have self-selected out of certain tasks and stayed more at home, right? Because of the leakage specifically. And that kind of self-selecting out of community mobility, or just taking yourself out of physical activity and exercise and strength training, can put someone at risk for, muscle mass loss, sarcopenia, and future frailty down the line. We're learning more and more about how continued strength training as we age is so important for maintaining muscle mass for older adults. And that kind of self-selecting out of exercise, even at a younger age because of leakage, can be a problem down the line. Similarly to things like pelvic organ prolapse, which can often start to affect women, after childbearing and things like that. I see women as young as in their 30s who have started to self-select out of exercise because they went on Google and Google told them that no exercise was safe with prolapse. And so people that used to be really active aren't as active because they're worried they're going to harm themselves, hurt themselves, make this thing really worse. And again, we start to set people up for decreased physical activity and increased, potential risk down the line. For something like nocturia, so someone who's getting up a bunch of times in the middle of the night, not only is that affecting their sleep quality, which we know affects so many other things as far as quality of life, but also if that person already maybe has some dynamic balance or visual disturbances, getting up in the middle of the night trying to rush to the bathroom sets someone up for increased risk of falls. And then once someone has fallen once or twice, we know that that increased risk extends down in the future. So just starting to think about, yes, frailty and screening your patients who are more frail for pelvic health concerns makes sense because the risk factors are there for there to be more pelvic health concerns, but also recognizing intervening earlier on with pelvic health complaints may set someone up for success and prevention for certain aspects of frailty down the line. So as far as like pelvic PT, what are we looking at? And then what are we doing about it? So I want to spend this kind of first little bit of time just talking about what we're looking at, especially in those first few visits. Again, pelvic PT is not just pelvic floor. It's looking at everything that could be contributing to the symptoms a person is experiencing. Subjective history is definitely not to be underestimated. I learn a lot by talking to people. And we'll go through kind of a thought experiment a little bit later with someone who's coming in with maybe stress incontinence, and all of the things that we kind of need to learn and questions we need to ask to be able to understand a little bit more about why that might be happening. But a lot of my first day and my first couple of days is really trying to ask pointed questions about what their symptoms are, in addition to getting a broader sense of them, their social support, right, their mobility status, all of those kinds of things. From an objective standpoint, again, I'm looking at movement screens. So if their leaking is happening while they're getting up out of a chair, I want to see how they're getting up out of a chair, how they're getting out of bed, right? How they're walking. What does that look like? Some standardized tests for function, right? So things like a 2-minute walk, 6-minute walk, grip strength, how many times can they stand up and sit down in 30 seconds? These things can seem like they're distant from pelvic health, but again, people with slower gait speeds, people with kind of decreased power out of the legs, if it's really hard for them to stand up quickly out of a chair, that can contribute to other deficits as far as pelvic health concerns. Strength assessment of relevant areas, balance, static, dynamic with dual tasking, right? Are they okay if they're only focusing on their balance, but as soon as you have them also think about something else, does that get really tricky? Abdominal assessment, and then what everybody's really worried about, which is a pelvic floor assessment. So a lot of times people are thinking only about that pelvic floor assessment, and that's the only way that we're gaining information. It's a way we gain information, but it's certainly not the only way. I do want to spend a few minutes talking about what that can look like and some of the things that we're looking for, hopefully to make it make more sense, but also potentially to make it less scary for patients, because I do think it can be a barrier to entry. So some things to consider with a pelvic floor assessment. I am doing a lot of explaining on the front end of the what and the why and the options, right? Recognizing that it's really important for patients to know that an internal exam, either vaginal or rectal, is never required. There is so much we can do, and there's so much information I can gain without that. There's certain information I can't get without it, but I have treated many people successfully never doing an internal exam, gaining information that I can't objectively any other way. And I'm never going to try and put someone through an internal exam when that is not what they want to do. Okay. It's also good to recognize too that, again, with trauma-informed care and for many other things, like people know that they can withdraw consent at any time. So if they say, yeah, I'm okay, I'm good with that, and we're going through the whole thing, I say, if at any point you don't want to do it anymore, or you need to pause, you need to break, you need to stop, we stop and we're done, right? So what am I looking at kind of externally? I'm looking at a lot of things, right? So tissue integrity, obviously as we age with like hormonal, menopausal, and other changes, that integrity can change, swelling changes, redness, pallor if there's any signs of like lichen sclerosis or other things like that. The position of kind of the perineal body and some of the other tissues can give me some idea of kind of general laxity in the system or tension in the system. The levator hiatus, so kind of how big the opening at the introitus is, can give me some information. What their muscle coordination is, right? So when I ask them to squeeze, what happens? When I ask them to bear down, what happens? Does the right movement happen at the right time? When I ask them to cough, what happens, right? Reflexes sensation, right? So if they've had maybe a kind of neurological injury of some kind, or have sensory integrity loss, right? Are they showing that along a certain pattern? Tenderness, right? So is there any tenderness to palpation in any of those external structures that we can identify? So for some of the superficial pelvic floor muscles that I can look at, these are some of the ones at the very front layer that don't require me to go internally. So those ones that you can see on the left with under the red, the green, and the blue, those are those initial kind of first layer perineal musculature, which are really the same in males as they are in females. Be surprised how many males are convinced they don't have a pelvic floor. That is a thing only females have. And so we can look at that in both males and females externally. Internally, either vaginally or rectally, depending on the indication, allows me to see a little bit more of true muscle strength, endurance, and power of both kind of the pelvic floor muscles and potentially the anal sphincter if we're doing more of a rectal exam. Tenderness and sensitivity of any of the structures that are more internally that I can't assess externally. I can get a little bit truer understanding of muscle coordination that's not just that superficial layer of muscles. So that kind of hammock from front to back, I can get a little bit more idea of what's going on when they're trying to squeeze and release. Evidence of pelvic organ prolapse is also something that's more easily discernible with an internal exam. Similarly, kind of with a rectal exam, looking at tenderness, tissue stiffness versus tissue laxity. When I push into something, is it moving as I would expect to? Is it moving more than I would expect to, less than I would expect to, all of that stuff. Again, I can't get a true muscle strength, endurance, power grade if I'm not internally just based off of the way that that's graded is through the full breadth of the muscle from front to back. Do I need that information in order to like change my treatment strategy? Maybe yes, maybe no. Does it help sometimes more with like prognosis? Sometimes. Again, which is why this is a conversation with patients of if I really feel like I'm missing something, here's what I feel like I'm missing. Here's why I feel like that information would be beneficial. Here's other ways that we can gain that information. So again, these are some of the muscles that I might be looking at a little bit deeper. This is that second layer of muscles over to the right, which is involved a little bit more with the continence mechanism around the urethra to be able to provide closure and a little bit of a backstop against that pubic bone, as well as that third layer of muscles, which again is really 3 muscles, but essentially that hammock from the pubic bone back to the coccyx and then the ischial spine on the sides. Of interest to this kind of muscle to the left and the right of the most lateral pelvic floor muscle is actually one of the hip rotator muscles, which is why, amongst other things, we're oftentimes looking pretty closely at the hips as well when people have pelvic floor dysfunction. Puborectalis is that middleist part of that levator ani, that kind of hammock muscle in the back. It is, because of its anatomy, oftentimes uniquely involved in defecation and creation of that angle between the rectum and the anus. For some people who are maybe struggling with defecating, if that muscle is having a harder time relaxing or doing kind of the wrong thing at the wrong time, then internally we can oftentimes feel if there's some coordination deficits there and give people some cues for being able to have a better strategy for emptying or put themselves in a better position for emptying. This is just giving you kind of all 3 layers on top of each other for a female patient. Like I said, we do have grading systems for things like strength, endurance, power. That muscle, just like any other skeletal muscle in our body, works a lot of different ways. Sometimes it has to work fast. It's a postural muscle, so it's oftentimes working a little bit at a low load over a long duration of the course of the day because it's kind of the very bottom of our torso. That doesn't mean it's at a max voluntary contraction all day, but it's oftentimes doing a lot more endurance work of helping with a postural stabilizer over a period of time. But then if I go to get up out of a chair or sneeze or cough, I need it to be able to generate tension more quickly, which may be a deficit for some people. So reasons I might not do an internal exam, obviously, number 1 reason is the patient doesn't want to do it. Okay, we don't do it, right? If there's significant vulvovaginal atrophy after menopause, an anal fissure, inflamed hemorrhoid, an active infection, severe pelvic pain, history of trauma, these aren't necessarily like, absolutely, I would never do an internal exam, but obviously we're going to have a conversation and we're going to be really mindful about how we progress with that. My number 1 thing is I don't want to either A, re-traumatize someone, or B, have them dread coming in, right? So pelvic exams, while there may be some discomfort based off of, prior pain, or some of these concurrent kind of medical or tissue kind of comorbidities, we are always going really, really slow and assisting with that tissue adaptation. I'm never going further than what that tissue or that person is okay with based on what they're currently experiencing. So if we're just kind of working right at the opening, and that's kind of where that patient's tolerance level and okayness level is as far as their their pain and their comfort level, then that's where we stay. We're never going to progress and just push past pain and discomfort just for the sake of trying to gain information. So again, I kind of talked through this a little bit. I can gain a lot of information externally. Coordination, tissue integrity. I can get some idea of kind of what their endurance is. I can get an idea of their sensation and their reflexes and tenderness on any of those external structures. Really internally, I gain more information about strength, power, endurance. I gain more information about internal structures that may be more tender or sensitive. More information about prolapse, position of some of those organs, and potential coordination deficits with things like defecation or other things like that. But sometimes I don't need all that information. The other thing I tell patients all the time is oftentimes people aren't having issues when they're lying down, right? So laying down is a really convenient position for me, but if they're only leaking when they're upright, or they're only having symptoms when they're upright, then I want to get a sense of how those muscles are coordinated and how they're functioning when they're upright, because oftentimes we do something totally different. So oftentimes kind of on the left where you see those two stars, those are areas where I may place kind of my fingertips even over clothes while someone is sitting or standing, and have them do a little bit of kind of muscle coordination for me, kind of squeeze, relax, push, cough, right, in that position, and see what is happening while they're upright. Because gravity is a heck of a force, and sometimes our bodies really change their strategy once we're standing. So I'll quickly go through this. This is really just to reiterate the point that kind of pelvic floor PT is not just Kegels. A lot of people will come in and say, well, I did Kegels and they didn't work. And I'm like, so happy you tried to do something. I'm so sorry it didn't work. Let's try and understand the factors as to like why that was unsuccessful for you. Yes, we have plenty of data that when people do a moderate amount of people, when they do a pelvic floor contraction, or when they're told to do a pelvic floor contraction, aren't quite doing it correctly or as efficiently as they could. So that's one thing. But I would say even more than that, Kegels / pelvic floor strengthening isn't always the primary impairment as to why they might be leaking, right? So pelvic floor muscle, just like any other skeletal muscle, we need the right amount at the right time, right, at the right velocity. So we can have an impairment in strength. We may have an impairment in endurance. We may have an impairment in resting tension. If we're not dosing their intervention appropriately based on the deficit that we're seeing, we're probably not going to see an improvement in their symptoms. To go back to kind of strengthening isn't always the answer. The muscles, and this is true for all muscles in the body, tend to be able to generate the most capacity or force when they're kind of around their mid-range to on a little bit of stretch. So when I think about like my grip, right? If I put my grip muscles in the shortest kind of position they can go, with my elbow all the way bent and my wrist all the way bent, like my ability to grip is not good, right? Because I've shortened those muscles over their whole range, and that is not a position in which I can generate a whole lot of force, right? So if we think about pelvic floor the same way, oftentimes I'll have people who are like leaking when they cough or they sneeze. And so they feel a sneeze coming down the line. And so they're like here, right? And then when they go to sneeze, they've got nowhere else to go, right? The muscle can't recruit anything else. And so when that muscle is in that shortest position, it's not actually really able to generate the kind of quick force needed to be able to close off that kind of mid-urethra in order to prevent that caudal loss of kind of pressure down and out. So oftentimes we are teaching people to be able to move through their full range of motion at those muscles, generating the right amount of force at the right amount of time. But if they can't fully relax those muscles, their ability to generate that maximum kind of or moderate amount of force when they need to is actually fairly impaired. So, and why does this matter? So this is my little kind of thought experiment of what are all the things my brain thinks about if I have someone that comes in that just says they're kind of leaking when they cough or they sneeze, right? So what do we know about what happens when we cough? Where could the breakdown be happening? What other questions do I need to ask? So from just a muscle perspective, Was the resting length of the muscle appropriate before the cough? Again, if they were kind of as short as they could go, when we cough, what we know tends to happen is that pelvic floor kind of right with that biggest part of the cough, with the biggest amount of pressure, they get a little bit of blip of kind of contraction. If that muscle's held in too much tension or it's not doing anything at all, when the cough happens, we're not going to be as successful. If they don't have enough strength to be able to push that urethra up against the pubic bone and put some closure in it, they're not going to be successful. Can they do that quickly, right? Coughs and sneezes are fast. So maybe they're able to do a 5 out of 5 pelvic floor contraction, but maybe it takes them 10 seconds to be able to get there. That's not super helpful if they're coughing or sneezing, which they need to be able to generate some force quickly, right? So coordination, timing, position. So maybe they can do that like kind of quick increase in pressure, but maybe they're not doing it at the right time. Maybe they cough and then they're kind of doing it afterwards, or they're doing it too soon. Can they do that multiple times in a row? If they're kind of having a coughing fit or having 3 or 4 sneezes in a row, can they do the right thing at the right time multiple times in a row? Is there an endurance aspect to that? Is there just a coordination deficit to that? Is it position dependent? Are they okay if they're sitting, but they're not okay if they're standing, or they're walking, or they're moving? What's the position of their body? We know when someone coughs, they tend to kind of forward flex because of what our, abdominals and intercostals are doing to help us cough. If they're already in a lot of kind of tucked position or flexion, which oftentimes a lot of our older adults kind of tend to live in that position a little bit more, when they go to cough or sneeze, they're already in a position of potentially a little bit more intra-abdominal pressure. And then when they put even more pressure in the system, they have a harder time managing that, right? So these are all kind of questions that I'm asking of when the leak is happening and what they're experiencing, to try and get an understanding of where we're focusing our energy. Other considerations, right? How full is their bladder? Hormone, tissue, endocrine, considerations. I see a lot of people as a cancer rehab specialist who are on an aromatase inhibitor or androgen deprivation therapy. And so that can definitely affect kind of not only urologic function, but also muscle mass. Surgical history, if they've had a hysterectomy and bladder and rectum are a little bit closer together and a little bit, more caudal than they used to be, that can sometimes affect how things function. Medications, pulmonary conditions that affect coughing, bladder irritants, even if it's stress incontinence and it's happening kind of with a big increase in pressure. We know that for people that it's not uncommon for the detrusor, the bladder, to do a little bit of contraction with a big increase in pressure, especially if maybe the bladder is a little bit irritated. I have some people who only leak when they cough and sneeze for the 2 hours after they've had coffee, but they're fine any other time, right? So bladder irritants can sometimes play a role, even if it's not urge specific. So again, take home point is we're just trying to fit the intervention to the person based on the specific impairments that we're seeing that person exhibit. So we are not going to get through all of these, but I wanted to start with urinary incontinence and kind of go through some of those. And then whatever we get to, we can get to. Any questions thus far? Because I'm talking a mile a minute. Okay, feel free to shout them out. So we'll start with urinary incontinence. There are different types of urinary incontinence, as I've alluded to. Kind of the 4 main types are stress, urge, mixed, which is kind of a combination of multiple, and overflow. I will add kind of functional incontinence to that, which is more of, I know I need to go, but I can't, I have a limitation that affects me in getting there, whether I have true mobility deficits where I'm confined to a wheelchair and I can't motorize myself and I need someone else to help get me there, but I can't, or I don't cognitively have the ability to recognize that I need to go. And therefore I'm leaking because I don't have the functional awareness to be able to process that. Of the people that I see that have mixed incontinence, even 9 times out of 10, when I say we can work on all of it, but which one bothers you most, it's the urgency and the urgent continence, because oftentimes that is the one that people feel least in control. It feels most unpredictable, it feels more severe, and it feels like more anxiety producing oftentimes for people. So this is the leak that's associated with like a sudden or strong urge to urinate. So urgency and urgent continence increase in prevalence with age. It affects both males and females, certainly. Depending on the study that you look at, so it affects more females or more males. The prevalence and incidence seem to be kind of all over the map. We do know or predict that it's underreported regardless. So this is a very kind of basic idea of what's happening with urge incontinence, but essentially bladder's filling up little by little. Obviously, if you are drinking fluid at a much faster rate, if you are taking something that's a diuretic, if you have a comorbidity that is increasing the rate of bladder filling, like diabetes or other things like that, bladder is going to fill up faster. What should happen is the bladder walls should stay fairly relaxed as that bladder fills up so that there's not an increase in detrusor pressure. But when we have kind of urgency or overactivity, the walls of the bladder don't do as good a job of staying relaxed. So they start to have some kind of electrical coupling and contraction there, which can eventually progress to bladder essentially jumping the gun, and that contraction of the bladder walls contributing to the leak before we've had an opportunity to get to the bathroom and have our brain go, yes, I'm ready, right? So bladder is basically jumping the gun before the brain top down says, yes, I'm ready to go. So things that we oftentimes see with urgency is it can happen kind of at any volume of the bladder. That's not to say that it's not often worse as the bladder fills up, but we certainly see people at fairly low volumes that are having issues. Leakage can be anywhere from a couple drops to full bladder loss. Oftentimes people will report triggers to their symptoms. Ones that I often see are movements or changes in position, especially if they've been stationary for a more prolonged amount of time. That key in the door phenomenon, right? Where I see my house, I get my keys out, I try and get the key in the door, and I just I can't quite get there in time, right? Seeing the bathroom, walking to the bathroom, like starting to take the clothes off, hearing running water, touching running water if they're doing the dishes. Certain kind of foods or drinks can sometimes be more irritating to people. This is not an exhausted list of what I tend to see, but there are these are triggers or situations that I often hear from people. I often see patients kind of fluid restrict and self-select maybe into timed voiding to try and manage. I'm going every hour just to try and prevent it, or I've cut way down on fluid just to try and prevent it. So there's definitely both modifiable and kind of non-modifiable factors as to why the detrusor may change its behavior. Again, these are neurologically driven, hormonally driven, visceral changes as we age, pelvic radiation and radiation cystitis if they've been going through treatment for cancer, changes in what's kind of inside the lining of the bladder, right? So if I have a liter of Mountain Dew versus a liter of water, the acid and potassium balance may respond differently. Constipation, right? So there's only so much room and space down there at the bottom. So if rectum is taking up a little bit more than its fair share, sometimes that mechanical physical pressure on bladder can cause it to behave in some certain ways. When I explain it to patients, I often explain it like this, which is because it's an organ, I only have so much control over what it does, right? Like it's not a muscle like my skeletal muscle where I have kind of more complete control over what it does when. But we have some things that we know about the bladder that we can do to influence how it's behaving. And the three kind of main categories of how I split that up is one is what's inside of it, right? So again, that could be your bladder irritant, right? If someone is having a lot of things that are really high in acid, and not a lot of dilution through their urine, then that may make the bladder lining a little bit more irritated. I have a lot of people who will chug water, and so that affects the rate of filling. If something stretches more quickly, sometimes it's a little bit less likely to stay relaxed. As well as, again, other irritants, kind of like I mentioned, or comorbidities that may make bladder filling happen at a higher rate. That second pillar is kind of more mechanical, right? So that may be a change in position. So I go to stand up and bladder was kind of more passively supported. Urethra was kind of passively supported on my seat. I wasn't really moving much. And then I stood up and gravity happened and movement started to happen. And a bladder that's already a little bit iffy, a little bit sensitive, doesn't tend to respond well to drastic changes in movement all at once. So that can sometimes irritate urgency. That is also where that constipation piece can come in, right? If there's more mechanical pressure on the bladder in that sense. When someone goes to get up from a chair, it's a task that inherently generates a fair amount of intra-abdominal pressure. So if they're also moving in ways like holding their breath, or it's a lot of effort for them to just get up out of the chair, they're going to create even more intra-abdominal pressure when they go to stand. And if bladder's already a little bit more likely to jump the gun, that additional increase in mechanical pressure can be a factor that can influence that urgency and that leakage. And then that third pillar that I kind of tell them is our brain piece, which is, I think, sometimes the hardest to wrap our heads around, but also one of our most powerful tools. This is something that we're still kind of trying to understand the mechanics of this and how it works. But one thing that we know is that people that have just at general baseline more stress and anxiety have higher rates of urgency and urgent incontinence. But also clinically, what I see is that when someone is experiencing urgency, that their ability to kind of provide that top-down neural inhibition to bladder is just so much harder. And so I think that kind of what gets set off in our system with that kind of fight or flight response makes it much harder for that top-down neural inhibition of bladder to stay relaxed. In addition to what tends to physically happen in our body when we're more stressed, right? And so that increase in tension with that difficulty with that neural regulation can make it so that an urge episode progresses into a leak, especially if we start adding movement and motion and things on top of that. What can be tricky is it's kind of a self-fulfilling prophecy with that kind of stress and that anxiety. When you don't make it to the bathroom, right? That's really stressful. And then the next time that situation presents itself, maybe even before you feel the urge, we're already kind of anticipating that something might happen. And I see a lot of people who, at first it was only with the key in the door. And then it was when I was walking up to the door. And then it was when I was parking the car, right? So we're almost like that brain is anticipating the next step. And sometimes we can kind of work ourselves up into a more urged state that's harder to control. So what do we do about it? So oftentimes we're teaching a lot of urge suppression, which is why in the beginning, I'm doing a lot of education on the front end, because if I don't talk to patients about the why of why urgency happens and why incontinence happens, if I was just just breathe, you'll be fine. They're going to look at me like I'm crazy, because that seems like the complete opposite thing of what they should do in the moment. Similarly, when I tell patients to actually kind of, after you stand up, instead of immediately trying to book it to the bathroom, let your system adapt to that big kind of change in position, change in pressure, change in gravity. Give your system a moment to kind of play catch up before you start adding a whole lot of movement and panic to the bathroom into the system, which can often help. Changing pelvic floor and belly tension to change a little bit of pressure on bladder and pelvic floor. Sometimes doing some quick flicks of pelvic floor takes advantage of some of that top-down inhibition to help bladder kind of stay a little bit calm. Distraction, visualization, there's a lot of things that we can do here to try and affect those things that we know can, that we have control over, that can help keep that detrusor kind of calm in the moment. Other things to consider, especially for older adults, is that both walking and balance, as well as sensory processing of the bladder, especially if we're maybe asking them to process that or manage it in a different way than they're used to, requires a lot of essentially like sensory processing, right? And cognitive dual tasking. And so one of the things that we're starting to look at urgency and urgent incontinence, especially on the way to the bathroom, is as like a cognitive dual task that we already know is harder for our older adults. And so in our training, kind of in PT, a lot of what I'll do is intentionally embed motor and cognitive dual tasks into what we're doing, not only to hopefully make that a little bit easier for people, but also in the moment where they're feeling some urgency, we've given them some tools and some strategies to be able to kind of do multiple things at once and think about multiple things at once. We will often do that in the clinic at like various levels of urgency. So we may start with no urgency and dual tasking. And then depending on the last time they went to the bathroom, I may ask them like, hey, when you come in next time, if you're feeling more confident, like maybe don't immediately go to the bathroom. Like let's play in this space of having a little bit of urge and seeing if we can kind of retrain that bladder to be able to handle some of these more complex situations and be able to stay calm. Again, other things that we're looking at, bladder diaries can be super helpful. Are they experiencing what they would describe as like 10 out of 10 urgency, and then when they go, they're only emptying like 100 cc's? Are they emptying in that moment like 400 cc's? Okay, that's a very different situation. Are they, again, globally really, really weak, so that when they go to get out of a chair, they're just exerting all of this effort and pressure just to get up, so that even if we're able to keep the bladder a little bit more calm, that amount of intra-abdominal pressure when they go to stand may just overwhelm the system. Looking at hydration, eliminating kind of fluid or dietary food triggers, working on their static dynamic balance as they are doing things to kind of prevent falls on the way to the bathroom, all of those things. Any questions on that? No? Okay. I have a couple things on stress incontinence. Again, we talked a lot about that kind of with the coughing or sneezing. For true stress incontinence to be present, the leak is not complicated by also that kind of detrusor overactivity, although it's really hard to tease out whether a little bit of that might be happening at the same time. Risk factors for stress incontinence, certainly age, BMI over 30, and smoking are some of our biggest risk factors for stress incontinence. Multiple vaginal deliveries being another potential risk factor. Endocrine modifying treatments for hormonally driven breast cancer or hormonally driven cancers for both males and females. Prostatectomy for males. These are only some of the risk factors that are out there. Prevalence certainly changes throughout the lifespan. And also the hypothesis with all of the incidence and prevalence data is that it's likely underreported. Clinical signs, again, this leak is usually happening faster and a little bit with like a faster activity, not always, but often this is, I go to pick something up, I went to bend over, I coughed, I sneezed, I laughed, I went to get up out of the chair, but there was no amount of urgency. Usually it doesn't result in kind of full bladder loss. Usually we're looking at a little bit less leakage per incident than potentially we can get with urgent incontinence. Again, this is something patients may fluid restrict and self-select into timed voiding to manage as well. So similarly with urgency, with stress incontinence, I'm looking at, okay, are there deficits in pelvic floor coordination, tone, strength, power, especially? Things that result in stress incontinence tend to happen quickly. So deficits in that muscle's ability to generate force quickly can be an issue. But also how the rest of their body looks and moves when they do the things where their stress incontinence is happening. Again, if their body's in a really funky position, if they're globally either really weak or holding onto a ton of tension, I see people who, again, are convinced that more tension is what they need in order to support themselves from the bottom. But then when they go to cough or sneeze or jump or do something, lift something up, if there's all of this tension and pressure in the body, they go to do something that generates more tension. And there's just so much pressure in the system that we lose pressure down and out. So for some people, I'm actually having them kind of relax. I would much rather jump on a trampoline than a cement floor, which is some of how I, will try and convince people to actually let some tension out of the system when they're doing some things which can help. Constipation management, prolapse management. These are all things that we're kind of looking at for stress incontinence as well. And then obviously you have people that have mixed incontinence. So they have components of both stress and urge. We can work on both of those things concurrently. Again, clinically, what I often see is that people are most bothered by the urge incontinence. Just as a, again, I've talked about some of this cognitive changes. Dexterity is a thing that we'll look at. Again, if they're getting to the bathroom, okay, but then it's taking them 5 minutes to be able to kind of get, lower extremity dressing managed because they have such poor either dexterity or osteoarthritic changes, or rheumatic changes, then that is something that we like. Do we add dexterity work into what we're doing? I have a hand therapist here. Is that worth exploring whether they might be able to provide tools and strategies for that? Other medical conditions that affect bladder filling. So sleep apnea for my patients with nocturia. Same thing for CHF edema. When they go to lay down at night, are they getting, more fluid that's being processed through the system and therefore they're getting up more overnight? I'm also a certified lymph therapist. So if people have swelling, I tend to be able to kind of concurrently treat that at the same time if it's affecting their urinary function. Also, just a plug that there are a lot of other patient populations besides kind of like older females that often can benefit from pelvic PT specifically and kind of like the urological kind of realm. So retention, nocturia, patients with multiple sclerosis and Parkinson's, we know tend to have a fair amount of urological and bowel function, post-prostatectomy, BPH. These are all things that are kind of under the umbrella of things that we can treat and look at. I'm not going to go through the next few again, just to be respectful of time, but just an awareness that kind of pelvic organ prolapse, bowel disorders, both constipation and fecal incontinence, as well as sexual function are all under the umbrella of things that we look at and do, in addition to just things like straight pelvic pain, are all, again, under our purview and are all oftentimes kind of interconnected if people have multiple things at the same time. It's not uncommon. Any questions on any of that?
Thank you. I have a lot of questions. I don't want to monopolize it, but I will start with, okay. In your experience, how much of pelvic floor, when women have a urinary incontinence, how much of that is really the bladder problem and how much is it rectal problems, and are you addressing both at the same time?
Yeah, that's a great question. It obviously it's patient specific. Especially as people age, but this is even true in the younger patients that I see, and part of that is where I am located. So I'm at St. Mary's campus in the outpatient center here, and we have really good communication and relationships with a lot of the urogyns and the colorectal surgeon and all that stuff here, which they know us well. So oftentimes we get a little bit of the more complicated people. So maybe it's just the patient population that I see based on my location, but oftentimes I'm seeing people with comorbid stuff. Very rarely is it yes, your pelvic floor is just weak and that's just why you're leaking. Or your bladder, there's detrusor overactivity and that's the only reason why you're leaking. That is why some of that subjective history and that kind of comprehensive exam is so valuable, because it helps me narrow down focus of okay, how do I pick out the things that I feel are the primary factors that are contributing to the symptoms that you're having, and how do we go after those at once, both from an efficiency standpoint, but also recognizing that going after constipation is probably going to help multiple things if we feel like it's contributing. I think pelvic floor gets blamed a lot more than it should. as a pelvic floor PT. I'm not saying I don't intervene at pelvic floor. I just think it gets blamed a lot for things that it is not responsible for.
May I ask a question?
Of course.
One, will you come back and give us the second half
Sure.
of your talk?
Sure.
Okay, and pursuant to that, for some reason lately in clinic, I am having a lot of my patients with complaints about how they are defecating.
Mm-hmm.
And I've kind of had to steel myself to have these conversations.
Sure.
Yeah, but they're quite focused on being constipated when I try to get a proper history. It doesn't sound like constipation.
Yeah. Yes.
I've started prescribing them. I forgot the name of it exactly, but you know, the little thing that your kid would stand up on
A
in
squatty
front of the
potty?
toilet when you were teaching him how to pee like a big boy?
Yeah.
Okay, well, there's something like that for people to put their feet on when they poop.
Yep.
But that's the only thing I know.
And that's a great first step. I agree with you. Especially normal bowel movements can be 3 times a week, 3 times a day, just kind of depending on what they look like and what that looks like for them. But especially if someone's used to going like 2 times a day and now they're going like 4 times a week. Now, obviously, if those stools are like all hard and they're straining and, you know, then that's a problem. But if they're like normal stools and they're okay to pass, if it's a change in their status, some people have like a difficult time adjusting to that. But there's a lot that we can do for bowel motility and defecation, because sometimes it's what's happening at the very end, like how they're actually emptying. But if they're having like really, really hard stool, I also need to work on how it gets from point A to point B, because like I can give people better strategies for emptying harder stool, but it would be even better if it wasn't hard. So in addition to, yes, things like fiber and hydration, we have a lot of kind of tools in the toolbox for helping bowel motility, so that by the time it gets to the bottom, it's actually an appropriate consistency for the body to be able to empty more efficiently. But yeah, it's something that we see a lot.
Because when I have generally it's women who are quite frail and kyphotic.
Mm-hmm.
I tell them to be hugging and leaning over a pillow, and maybe that'll help.
Mm-hmm.
But I'm just making this up. I'm tap dancing. I know that they've all been to GI and had unrevealing colonoscopies. So
yeah. And certainly to your point, we talk about kind of toileting posture and position for people. And for some people, they may have non-modifiable skeletal deformities that may limit their range of motion. If there are things that are modifiable that we can change to help them get in a better position when they empty, but also just to like, again, move more and better. When people move more, the bowels move more. And when bowels are a better consistency by the time they hit the bottom, that, you know, rare reflex of how we are cued that we need to go tends to work better. And so it's, yes, what's happening at the very end, but also kind of how we get it from point A to point B. But those are certainly things that we see and that we work on. A squatty potty is a great way to start.
Oftentimes they're in one of these multi-generational households where there is the little thing for the latest grandbaby to stand up on, and that works.
Which is perfect. Yeah. Yep.
Is there something specific we should do in advance of sending someone to you, or in preparation, or either things to try or coaching and someone to get ready that would help you to streamline the process?
Sure. So I think one of the my brain is going a mile a minute, so I'm trying to not go down 17 avenues at once. I think a simple explanation of like some of the things that we're looking at, I think a lot of people get really freaked out by what the exam might look like. And so I think reiterating that nothing happens that they don't want to happen, right? We talk thoroughly about different options for gaining information about what's going on in that area. Oftentimes day one, I don't even go there because there's so much data to gather and subjective information, and I don't even get to looking at kind of like pelvic floor more specifically until down the line. And I think that can sometimes help people kind of put people's minds at ease. I also think that recognizing that like it can be something that I've said to patients that I've heard feedback on is like when people find out that I do this like all day, every day, I'm like, the only patients that I see are pelvic health and cancer rehab. That's all I see all day. And there are 4 residents out of this office and another full-time staff person. Like there's enough people that are dealing with what you're dealing with that like there are multiple staff people here that are just seeing that. And I think that it can help people feel less alone because this can feel super isolating, especially with older adults and generationally that are a little bit potentially less likely to share and talk about it. So they can feel like they're on an island. Sometimes sharing that like, this is what I do all day, every day can, for some people, put their mind at ease. And so that is, that I think sometimes can be helpful. Also, if they ever want to talk to one of us, I've talked to plenty of patients before their initial because they're just like, what does this look like? What are you going to do? I talked to my daughter. She said this, she looked on Google, she read this thing. I don't know. I've talked to plenty of patients on the phone to kind of talk through what we might do, what that can look like, what we can work on. And that sometimes helps to put people's minds at ease too.
Susan, you've got a
We did
question.
a consult in Epic. What
Yes.
do we put, what do I type into Epic to send you a referral?
So this is a great question. And I tried to include it. I asked my, our former program manager who's done a lot with kind of like the Epic training and referral. She didn't get back to me in time, but she's going to send me the information of exactly how to put something into Epic, and then I can forward that along to all of you. I know there is a way of putting in a pelvic script into Epic, and then it'll go to our central scheduling, and then they will find the clinic that's closest to them. So here are all of our pelvic health clinics. The ones that are have a box around them, have therapists that see both males and females.
And I have a flyer that I'll forward to everyone here that you can have as well.
Yeah.
So, and Susan, you've been patiently waiting.
I have, thank you. So I apologize. I don't have a lot of information on whether this is old school treatment or new school, but I've got 2 patients that come to me in outpatient clinic, and they both have pessaries or however you say it. Yeah. And so I'm curious what your thoughts are on that as a, like, I seem to worry about them with those. I don't know. What, can you tell me more?
I can. Do you have a specific worry?
Well, in my brain, and I haven't looked it up to be able to back it up, it just feels like having a foreign object someplace for a long period of time could add to infection.
Yeah. So I also, when I was kind of like learning this world and learning about pessaries and things like that is also my kind of gut feeling. In talking with the urogynecologists, who are typically the ones that are managing pessaries, they are doing a lot of pre-work to make sure that tissue integrity is appropriate. There are pessaries of all different shapes and sizes to try and ensure that you're getting an appropriate fit. So oftentimes they'll kind of fit someone, send them home, have them come back and see like, okay, let's remove it. Let's see what tissue integrity looks like. Is there any skin breakdown? Was the person having any spotting? Do I see any signs or symptoms that the tissue is not tolerating this well? I have had people as old as like in their 90s have an internal pessary that they go in they don't take it out. They go in every 3 months. The urogyne takes it out, cleans it, puts it back in, and have never, ever had an issue with it. It's medical grade silicone, is what they're typically made out of. Also, more urogynes nowadays are often also doing some concurrent vaginal estrogen to try and help with the tissue integrity and bulk in that area. I think a lot of it is about getting an appropriate size and fit, because if it's not the right fit for that patient, then I do think that you potentially are more at risk for tissue breakdown with friction. But with an appropriate fit, I've seen people do remarkably well.
Okay.
Mhm.
Thank you.
Yeah.
Okay, well, that was an amazing talk. Thank you so much. And I will be emailing you, Dr. Dougherty, and seeing if we can do part 2 of this.
Sure.
because we have lots of interested individuals in this topic and patients that we take care of. So I will be in touch, and thanks everyone for your questions and your attention, and have a great rest of your afternoon.
Yeah, thanks so much. And like I said, once I hear back from Megan, as far as like specific instructions on epic referrals, I can send it along to you as well.
Wonderful.
Awesome.
Thanks.
All right, thanks so much. You're so welcome.
Bye-bye.
Bye.